Hopefully this one works. Okay, now we're live. Hopefully this one works. Okay, now we're live. Hopefully this one works.
Okay, we're live, I think. So, hello to everybody who have come along. It may be a good idea for those of you here to, or at least we are here to sort of mute while the speaker is, so we don't have any sort of cross, so to speak, intersection of words and videos and audios in these days of digital. But to begin with, a very, very warm welcome to everybody. And of course, today it's an auspicious day. 100 years from the day when the first dose of insulin was given. I have been reliably informed, and maybe in the quiz, so very sorry if this is really upsetting the quiz, that even though this was the day when the first dose was given, it actually wasn't the dose that worked. So there's a trivia to begin with. The actual day the first dose it worked was 23rd of January, I've been told. So, so that's an interesting in its own right. So what we'll do is, you've seen the program, we've got a fantastic array of speakers, people living with diabetes, their experiences. We have got, as I've said, in my opinion, is the person in type 1 diabetes. No, it's not Pratik Chaudhary, it's Professor Stephanie Emil. But Pratik is here as well, my longtime friend and absolute confidante. So along with that, we have the fantastic colleagues across Team Diabetes 101 and obviously the DSN forum here, our nursing colleagues to help us guide through the day. So I will shut up now, just apart from that, and I am going to bring in Vicky to say a few words.
Thank you, Partha. Yes, I'm Vicky. I'm sure most of you know me through Twitter. I'm one of the 101 team members and also part of the DSM forum. So absolutely, what a fantastic day to be celebrating. And we thought, what better way to celebrate this special occasion with the 101 team and their special guests tonight, where we will talk all things insulin, past and present. So first of all, we will hear from two people living with diabetes and their experience of using insulin. Then we will move on to hear from Professor Stephanie Emil and her presentation with a travel through time, looking at where we started and how insulin therapy has developed through the years. Next up, we've got Professor Pratik Chaudhary with his vision for looking ahead and what the future may hold. We will then move on to, it was going to be the dynamic duo, but it's a different dynamic duo. It's Amanda and Beth, who will host the all-important Insulin Quiz. So make sure you've got your pens and paper at the ready. And then finally, we'll hand over to Becky and Tamsin for the closing remarks before the evening comes to an end. Hopefully any questions that you have, if you pop them in the YouTube live stream, we will do our best to answer them over the next 2 hours. So without further ado, let's welcome our first speaker, who is Stephen Casey.
Good evening. If you put up the first slide, please.
Arthur, I haven't had the slides off you.
Have you got the slides on?
Bear with me. Let me share the slides. If it's not gone through, I'll share it. I've got it with me. Bear with me, Stephen. 1 second. Let's have a look. So let's see if this technology does the job. Can we see it? Yes, we can. That's the first slide, Stephen.
Okay. If you introducing myself, I got diabetes back in 1957 when I was 2 years old. Next slide, please. Back in those days, there were glass syringes and metal needles. And in fact, the needles that you see there in the image look shocking as to their size. But I can assure you, on one occasion, I actually got such a thick needle from the pharmacist. And what you used to have to do back in my days for an insulin injection was boil the syringe, boil the needles in hot water, take them out of the hot water, and store the contraptions in surgical spirit. Next slide, please. My mum and dad had to deal, if you can go back to the sort of injector.
Inject, sorry. Oops.
That, you just went past it.
There we go.
There we go. My mum and dad had to deal with a 2-year-old to be given injections. And you can imagine that'd have been pretty horrific. And I've got kids, I've got 2 daughters. I wouldn't like to have injected them. And my dad latched onto this syringe gun. And it really looks quite medieval. And I reckon they still use it to this day for injecting cattle. And I was no beefy cattle when I was born. But that was used for me for 6 years in getting my insulin. Next slide, please. One way of monitoring the actual sugar in your system was only by urine. So you'd take so much insulin and you'd see what was going on, but the sugar was only identifiable in the urine. And you had to take 2 drops of urine, and I even did this at 6 years, 7 years old, 5 drops of water, you put it in a glass test tube, and you added this toxic tablet, which if you touched it, would actually burn the skin of your hand. And as a patient, you would very gently drop it into the liquid and watch it froth and foam, and bubbles came off, and also white fumes. And that liquid would turn a color. And if you had no sugar in your urine, it was a navy blue color. If you had 2% of sugar in your urine, it was a bright tangerine orange. And there were colors in between saying 1% sugar and 1.5% sugar. Blimey, imagine health and safety passing that today. Next slide, please. So in my early teens, there was more foods and sweets that began to become available. Prior to that, you got 1 injection of porcine insulin in the morning. That had to last you all day. So the diet was extremely regimented. You only got so many units a day to eat because, in theory, you'd only had 1 injection of insulin, and that had to last you all day. So things were very, very rigid back in my early teens. Was I a naughty teenager? Goes without saying, yes, I was. Fortunately, I didn't get complications. Diabetes rarely stopped me doing what I really wanted to do. And it wasn't too difficult. And one of the things I want to express about the use of insulin, it's the difference between your body doing it for you and you doing it. That's the only difference. So if you have the philosophy of, in all aspects of life, I'll be careful, and I'll take moderation, in other words, balance, as the famous diabetic magazine is called, it isn't a problem, diabetes. It can be a challenge, but it isn't a problem. Did I drink? Did I get drunk as a teenager? Yes. Maybe I was very fortunate because in being a diabetic and knowing I had to watch a little bit, I never made myself incapable with drink, because in the back of my mind, I didn't like the after effects the next day, but also I didn't want to try and manage knowing what was going on. Was it alcohol or was it blood sugar? So the aspect about insulin and the use of it generally as an end user is moderation, as is with everything in life. Next slide, please. So I've passed to the next slide. So what were the complications of diabetes? Well, yes, we all hear about complications. But I can honestly say that I've been very fortunate. I've lived a healthy life. It hasn't stopped me doing many things. But yes, there was one complication, and I was extremely lucky that I was in the right place at the right time. I was seen to have aneurysms, and I guess this was fortunate because I went to an optician. I needed glasses when I was 6 years old, nothing to do with diabetes. The optician fortunately saw something, and at that time, it ended up me being sent to Manchester to get laser light treatment. And I actually was fortunate enough, not knowing it at the time, to be passed on to an optician in Manchester, a Dr. Rossen, who was leading the way forward in using laser light treatment. I got the laser light treatment. I've had it twice since in all those years, and I have no problems at all. And what's fantastic today is the regular up checks. Next slide, please. So after being 16 years old and having had diabetes when I was 2, technological changes were really beginning to kick off. Maybe that was partly because of the space age as well. Diabetes control and the monitoring of diabetes was changing. There was a change from it being purely porcine insulin to it actually being man-made insulin. And this was an incredible change, partly driven because I believe the comment was, well, there aren't enough pigs in the world to actually help the number of diabetics we're seeing. But there we go. The big change really after I was 16 were doctors were now more informed. There was far more accessible things, treatments for doctors to actually look into. Disposable syringes, well, that's not a high technology, but the ultra fine needles that were being used in delivering insulin, wow. I can show you, well, I did show you the image of the huge, thick needle that was used prior to the beautiful hair-fine needles that are available today. That's wonderful. And of course, blood sugar testing came in years ago. And now today with Libre Style or Freestyle, we can have arm sensors that are monitoring sugar in the body, not in the blood, all day long. And as I mentioned here, man-made insulins, which are now long-acting and fast-acting, which means although we're controlling diabetes and our body isn't, we're almost doing the same as our body by being able to have this combination. That's a wonderful technology. Next slide, please. Have I experienced hypoglycemic attacks? Yes, I have. I'm sure we all have. In my years of diabetes, have I needed help? Well, actually, yes. I think on about 4 occasions in 65 years of having diabetes, I've actually had to have someone come out and help me. And I don't want you to think, oh, that's only because I was a goody-goody with my diabetes. Because as I said to you, I did things I maybe shouldn't have, but I was always checking. I was always wanting because I was responsible. Have I had extreme hyperglycemia? Yes, I have. But what I emphasize to you is today, with the technology, I've actually been able to dramatically reduce the incidence of either the extremely low blood sugar or the extremely high. And with a new technology, that's actually shown that I'm doing it with the HbA1c. Again, fantastic technology. Next slide, please. I don't want you to think, oh, yeah, he's just saying, oh, isn't it wonderful? Isn't it wonderful? Yes, technology brings fantastic changes, but technology can have a challenge on occasions. And for me, as an insulin-dependent diabetic, the main challenge was changing from porcine insulin to the human recombinant insulin. And what was the challenge? With porcine, by the way it worked in my body, I lost the ability to actually sense that I was going into a hypoglycemic attack. When I have had hypoglycemia with human insulin, I'm not so aware as I used to be, but I do now still recognize there is something going on here. As I say, not as noticeable as porcine, but yes, you can begin to pick up. So there's a challenge, if you like, in the new technology, but it works, and it works damn well good. Next slide, please. So final comment or closing comment, and I'm not trying to be funny about this, I'm not trying to win people over, because I had to watch in my life, and not as like a sword of Damocles over my head, but I had to watch what I did. That's actually been a huge benefit to me at the end of the day, because when I look at my so-called non-diabetic healthy friends of the same age, they ain't as healthy as Steve Casey. And I would like to believe, truthfully, that part of the reason for that was I didn't overeat and didn't become obese. I didn't do anything really too extreme. And you know what? That in itself is a good way to a good life. So I wish everyone with diabetes, health, happiness, and new technology. Thank you.
Thank you so much, Stephen. What an insightful story to listen to, and how things have changed in the time that you've had diabetes. Thank you so much for sharing. I don't think there are any questions directly for Stephen at the moment, but if we have time, if there are some and there's time at the end, then we'll come back to you, Stephen, if that's okay. So next up, it's Angie Whitmarsh. Are you sharing any slides, Angie, or are you just, okay, fabulous. I think you're just on mute. You just need to unmute and then we're good to go. Fabulous. Thank you, Angie.
Thank you. Well, I'm type 2. I have type 2 diabetes. My first encounter with diabetes was back in 1989 with my first pregnancy. And I was told quite early on I had sugar in my urine. I'd basically taken my mum to one of the antenatal classes and said, oh, come on, mum, this antenatal appointment will be fun. You haven't been to one for years. And the nurse came back in and said, you've got sugar in your urine. And I said, well, what does that mean? And she said, well, basically, it means your kidneys are failing. I didn't hear another word after that. My mind kind of took off. And in my mind, I was delivering the baby. Hello? And then being sort of rushed into theatre and having a kidney transplant. So it really was not explained very well. I then went through the sugar tolerance tests, and I was told the baby will be very large. I was 2 weeks over, they let me go 2 weeks over, and the baby was £10.15 and a half. The most surprising thing that I felt pretty rubbish during the pregnancy, but then I didn't know if that was pregnancy or if it was because of the gestational diabetes. But as soon as the baby was born, it was like a light switch and everything went back to normal. And then that was that. My second pregnancy in 1992, it happened again, but the symptoms seemed to be a lot more extreme and a lot worse. And I actually ended up being hospitalised. At the time, I had no idea what was going on, and it certainly wasn't explained to me what was going on. But at diabetes conference only a few years ago, there was a nurse who explained HHS, and listening to that and how she described it, I then realised that's what had happened to me, and that's why I got hospitalised. Again, they said the baby will be large, so they induced me, my due date +1, and the second baby was £10.11. But again, everything went back to normal. I wasn't given any kind of advice or anything like that. So I actually said, now this has happened twice, is there anything I should do? And I was basically told, well, tell your friends and family, and if you collapse later on in life, get them to test you for diabetes. So I took that to mean that it wasn't that serious and there wasn't really anything I should be doing, and off I trotted. 2008, I started to feel really quite rubbish. I was extremely tired. I was getting lots of urine infections. I had sores on my feet that wouldn't heal and things like that. And I basically trotted backwards and forwards. It took them a year to diagnose me with type 2 diabetes. And I was straight away put on medications. They didn't seem to work very well. They didn't get under control. And there were lots of conversations about insulin, which I shied away from completely because I didn't want to be using any kind of needles or anything like that. They did put me on to Byetta, which was, again, not a good solution for me. I was working at the time as a full-time police officer raising 2 teenagers, and the Byetta that I was given at that stage in 2008 was inject an hour before you eat. Well, trying to do my job and look into the future and think in an hour's time there won't be a road crash or there won't be some other incident and I'll be able to actually sit down and eat, it was just not good for me at all. I mean, I was lucky, the job was very good. I had some very good supervisors and they were very supportive. So then in 2009, I was finally convinced and persuaded to go on insulin, and it was almost like my life changed almost overnight. The tiredness that I had felt had gone, and it was almost like I had my life back. Prior to being on insulin, I would literally do my job, come home, my husband would do all the housework, I would literally go and lie down, get up, cook a meal for the family, eat the meal, and then basically go back and lie down again. And that was really my whole life. But once I started on insulin, it actually made everything a lot more manageable and a lot easier for everything to go through. They did lie to me initially because I was, well, if I go on insulin, if I take this advice, does that mean I take less tablets? And they said, yes, of course. Well, actually, I'm on more tablets than what I was. But I wouldn't go back, and I wouldn't say I'd come off the insulin because I think I'd be frightened of feeling as rubbish as I felt before I was on it. I run a local support group, and I constantly have members of the support group saying things like, oh, they're talking about putting me on insulin, and oh, I'm resisting it. And when I talk it through with them and I say to them, my experience has been, I have felt so much better since changing over and taking the insulins. Yes, it is 4 injections a day. Yes, it does impact quite a bit on everything you do, particularly, well, not COVID times, but any other time, going away on holiday, trying to work out your different medications, going through time zones with insulin, but it's all manageable, and I'm just grateful that I feel so much better, and I'm grateful to be on the insulin. Thank you.
Thank you very much, Angie. It's really nice to hear such a positive story with regard to insulin. And as you mentioned, it sounds like you're doing some great work there with your support group, because obviously as healthcare professionals, we do come across people who are very sort of hesitant about going onto insulin, those with type 2 diabetes. So it's absolutely fantastic to hear such a positive story. So thank you, Angie, for sharing that. Do we have any questions at all, Becky?
No, not in the comments at the minute.
No, okay, fabulous. So moving on then, our next speaker, I'd like to introduce Professor Stephanie Emil, who is a professor at King's College Hospital specialising in type 1 diabetes. And she's going to talk us through a travel in time as to what has happened over the years and how insulin has developed.
Thank you very much indeed. I'll just get into the beginning of the presentation. At the moment, I seem to be towards the end. Hopefully I can get it to go to the beginning. Good. Right, so, well, thank you for the introduction, and thank you very much to Partha and the organisers for inviting me to join this symposium. Although after those two fantastic and very personal presentations, it's a very tough act to follow. When Partha called me about this webinar, he asked me if I would speak about the history of insulin, and it wasn't until later that I saw my title as a travel through time. So here we go with a travel through time and the history of insulin. So the reason that we're celebrating today is that, as Partha told us, it's the 100th anniversary of the first administration of insulin to a person with type 1 diabetes for clinical benefit. And although, as he pointed out, this first injection wasn't entirely successful, success did follow. The first patient was Leonard Thompson. Many of you will have heard of that. And almost within a year, people in other parts of the world, from Canada, where insulin was originally used to treat people, then people were using it. And a year later, a guy called Robin Lawrence, R.D. Lawrence, received his first insulin injection at King's College Hospital, and went on to found not only the diabetes service at King's, but also what was then the Diabetic Association, now Diabetes UK, which he set up with the American author H.G. Wells. Now, the story of the discovery of insulin is usually the story of Frederick Banting and the medical student Charlie Best, and the discovery in Toronto in 2021. But I'd like to start with the prequel, because none of these changes in science ever happen out of the blue. So I'd like to start our story back in 1869 with a medical student, Paul Langerhans, who described, he was looking at the histology, the structure of the pancreas under a microscope, and he described islands of clear cells in the pancreas that stained differently from other cells and had very good nerve supply, but he didn't really understand the significance of those. Another very famous and important discovery in the movement towards finding insulin was in 1889, when Minkowski and von Mering described the effects of taking the pancreas out of dogs. And if you have time to read the text here, you can see this is a very beautiful description of diabetic hyperglycemia with ketosis. But what Minkowski noted was that the dog was urinating a lot, and he thought to test the urine for sugar. It's worth mentioning that Minkowski later said that if he'd known that the father of physiology, Claude Bernard, had recently said that no one could survive or nothing could survive a pancreatectomy, he would never have done it. And it's also in the present COVID situation, where we're all sitting here on our laptops and computers at home, it's worth noting that Minkowski only did this operation as a result of a corridor conversation that he had with Joseph von Mering, who had failed to achieve making any pancreatic extract by other means. Moving rapidly onwards, in the 1900, Eugene Oppie at Johns Hopkins University in Baltimore noted, again looking at the histology of the pancreas, that the islets of people with diabetes were very different, and they looked as though they weren't recognizable as islets under the microscope. And it was in 1910 that Ernest Sharpie Schaefer actually coined the term insulin when he was having a hypothesis that the pancreas made a single substance, absence of which caused diabetes. So that's where the name comes from, before it was actually isolated. And the isolation that Banting and Best and their team achieved in 1921 was not the first, and nor was it the first time that pancreatic extract had been given to patients. Now, I don't have time to go into all these details, but this is a list of some of the other groups that had extracted something from the pancreas, importantly an aqueous extraction, because that was the one that worked, and used it to treat either diabetic dogs or people. And the extraction method used by E.L. Scott in Chicago in 1911 is actually referenced by Best in his publication in 1921. But in 1913, there was a case report of a successful resolution of symptoms in someone with diabetes from a pancreatic extract. And indeed, this group had communication with the Toronto group later to talk about, this is actually a letter from the patent lawyer that was advising the Toronto team. The one I want to mention, because of my own interest in hypoglycemia, is the first recorded hypoglycemia induced by a pancreatic extract was in 1919. And one should just mention Nicolae Paulescu. His work is very rarely quoted. He actually did the experiments in 1916 and then got whisked off into World War I, but he had a sinister reputation as coming from the extreme right of politics, and his work is almost never referenced. So that's the prequel. We now come to the movie and the discovery of insulin, or the making of a pancreatic extract that treated diabetes by surgeon Frederick Banting, medical student Charles Best, the head of the department, J.J. MacLeod, and the biochemist James Collip. And I'm not going to go into the details of this story because it is beautifully described in the History of Insulin written by Michael Bliss. This is the 25th anniversary edition from 75 years ago. But it is still available and it's well worth a read. And if any of you had the opportunity to hear Michael Bliss, you will know this story. It's a fascinating story. There's another very personal view from Thea Cooper and Arthur Ainsberg, who talk about the discovery of insulin from the point of view of an early patient, an American woman called Elizabeth Hughes. And just adding to the beautiful history that we had from Stephen earlier on, then Robert Tattersall's biography of diabetes I can recommend. But I'm just going to pull out a couple of points that I think are really interesting from Michael Bliss's story. So we know that in January 1922, there was an injection to Leonard Thompson, the first injection. And within a few months of that, we find that the team is actually thinking about how to bring insulin to mass production, and in communication with Eli Lilly about this. They didn't take it forward immediately because they wanted to produce an abstract of an extract that was both pure and reproducible and reliable before they moved into any collaborations. But they did move very rapidly into a collaboration with the company Eli Lilly to make large quantities of insulin. It was known as Iletin, and originally it was 4 units per mil. So this is U4 insulin. And for the next several decades, we had insulins available to us in concentrations ranging from 4 to 80 units per mil, U40 to U80. Just to be unbiased in this, August Crowe actually went to Toronto to look at what was being done, and was given permission to bring the manufacturing method back to Europe. He brought insulin to Scandinavia, and a year later the not-for-profit Nordisk Insulin Laboratory was set up. Just a financial point, in 1923, Banting, Best, Collip, MacLeod and Fitzgerald sold the patent for insulin to the University of Toronto Board of Governors for $1. They did it because they wanted to take out a patent for this purpose written here, to prevent the taking out of a patent by someone else, so that anyone could be free to prepare the extract and no one could secure a profit from it. I just leave you to think about the insulin prices and the range of prices across the world to see whether or not we have stuck to that ideal. So that's the movie. What about the sequels? Well, having been given insulin as an extract of animal pancreas, we remained with, as Stephen pointed out, we remained with extracts of animal pancreas for a very long time. And the original insulins were just fairly fast acting and needed to be given more than once a day. So there was almost immediately attempts to change the action profile of insulin, partially with the idea that you might be able to treat insulin with a single injection a day. And the first one was when Hagedorn and Jensen used protamine, a fish protein, to bind the insulin to slow its release from the injection site. And that gave us the beginnings of the intermediate and long-acting insulins. So between 36 and 54, there were a series of insulins that were made that were retarded in their action. I just mentioned the development of U100 insulin here because actually, although it wasn't thought that it would happen, changing the concentration of insulin does change the time course of its action, as we now know very well from the glargine U100, U300 story. But the important change was actually the cleaning up of pancreatic extract to monocomponent highly purified insulins in 1978, done by chromatography. That really made the fast-acting insulins faster and shorter, and was probably the biggest improvement in the insulin action. Now, just a brief pause to look at other things that happened with insulin. It was the only available pure protein preparation in the 1950s. That was bovine insulin from Boots. There were a lot of insulin manufacturers in the early days. And Frederick Sanger sequenced insulin in the 1950s. It was first synthesized, in fact, in China. A lady called Dorothy Hodgkins solved the crystal structure of insulin. But for our story, the important first is that it was the first human protein to be synthesized using genetic engineering, taking the human insulin gene and putting it into an organism that could make it in bulk. And that really paved the way for the makings of the other insulins that Stephen referred to. Genentech in '78 created a genetically engineered human insulin by putting the human insulin gene into E. coli. It was later replicated in yeast. But basically, those organisms then churned out a large amount of insulin with the molecular structure of human insulin. And having been able to genetically engineer the insulin, it then became possible to develop the genetically modified insulins, where that amino acid structure could be changed by 1 or 2 or 3 amino acids to give it special properties, either to make it faster acting, as with the fast acting insulin analogs, or to make it slower acting, delay its absorption through various techniques in order to give us the peakless background insulins, Levemir and Lantus. And then most recently, we've had the ultra long acting insulins such as Degludec and U300 glargine. The change there is just in the concentration, remember. We have had, and we've still got, some inhaled insulin, which is very fast in its action. The inhaled insulin that's now around from Mankind, Al Mann, the owner of the company that did that, was hopeful that it would be so fast that the dose wouldn't matter because it would just come in, do its stuff, and leave the body very quickly. I'm not sure that has been quite the case, but it is certainly a very quick and short-acting insulin. And then the manufacturers are continuing to make changes to give us our ultra-fast-acting insulins. And why do we do all this? Well, the reason Stephen mentioned this is doctors got to understand more about what insulin people with diabetes needed. And this really depended on the development in the 1960s of an insulin assay. And this is a famous profile from Ken Polonsky's group in America showing you the changes in insulin level in the blood over a 24-hour period. And of course, there is no way that you can reproduce that sort of profile in your blood by a single injection a day. And even with all these wonderful insulins that have now been produced for us and now available to us, still a single injection of insulin is not going to reproduce that rise and fall of insulin that you have every time you eat, and the background of insulin that is there to control the body's own sugar production during the periods when you're not eating. I just want to mention in this potted history of insulin, there are the other developments that have gone along with the history of insulin that have changed how we support people with insulin requiring diabetes. So just looking briefly at the history of the technologies, insulin pumps were first developed to infuse the insulin rather than give it by injection in 1978 at Guy's Hospital in London. The first insulin pen was actually devised by a Scottish GP in the early 1980s. Pumps became commercially available in the 1990s. And then, of course, we had the onset of cell therapy for insulin replacement with islet transplantation in 2000. And now with more sophistication of these technologies, we're working with hybrid closed loops where the insulin is driven by continuous glucose sensing. But there are also the human factors. And I just want to point out that this has always been the case. R.D. Lawrence, when he was setting up his first diabetes clinic in 1925, produced a book, The Diabetic Life, with advice about diet and dosage for the person with diabetes and the physician. And in 1983, we had the development of the diabetes teaching and treatment program by the Dusseldorf group in Germany to try and help people really learn how to manage their diabetes and manage their insulin around their lifestyle rather than the other way around. That hit the English-speaking world when it was translated into Daphne in 2000. But the point I'd like to make is that we still need those sorts of programs that engage the people with diabetes in the use of insulin, because even with all our current technologies, we still don't have perfect glycemic control, and we still have people experiencing hypoglycemia and indeed hyperglycemia. And so new programs are still being made and still wanted. So where are we now? Researchers before and since the 1921-22 centenaries that we're celebrating have developed our knowledge and understanding of insulin action. Academic and commercial interests have brought us increasingly sophisticated insulins and technologies for their delivery. A greater understanding of physiology and pathophysiology offers people with diabetes better outcomes. Stephen alluded to this, for more work. At present, I would argue that how the insulins are used matters at least as much, if not more, as which insulin you use. But where are we and where will we be 100 years on? I'd just like to finish with this quote from before 1922, when Oskar Minkowski said, "We hope that recognition of the etiology of diabetes as deriving from a functional disturbance of the pancreas will someday lead to a successful therapy." In 2022, I think we could argue that we have a fairly successful therapy for insulin replacement. But looking to the future, there are things that we still need to perfect and get a completely successful therapy. And I hope the next speaker, Professor Pratik Chaudhary, will give us some information about where we're going towards that. Thank you.
Thank you so much, Prof. And to those who are here, this talk, all of it is going to be recorded for you to have a listen to. And without saying too much, all of you know very well in the regard that not just me, the whole type 1 diabetes and wider diabetes community holds Professor Emil in regard. And I must say, Prof, that was probably one of the best CPDs I've had in the last decade. So thank you so, so much for that. So that was brilliant, and thank you. So before I introduce the next speaker, I'm going to actually use this opportunity, which ties in a little bit, I've got a little bit of a plug, but also ties in with what you have just heard. So I'm just going to share my screen for 1 minute and show you this. So today, this comic book has been launched, and the comic book is about the 100 years of actually insulin. And if I could show you this, sorry, in the background, you can see my 2 dogs for a minute, that's fine. But this comic book actually touches upon Dorothy Hodgkins, her lecture, Frederick Sanger, the formation of the first British Diabetic Association, R.D. Lawrence, all of that. So actually, it's a comic book which goes through a lot of the things that has been talked about. So thought I would mention that. It's online if you want to have a look at it. It's from Revolve Comics, the type 1 diabetes comic book done by Mayank Patel in the main with people with type 1 diabetes. So thank you for that. And the next speaker to introduce is my very good friend. And, I spend a lot of time about, making jokes and banter about him, but somebody I respect a lot for what he brings to the table. His knowledge, his overview is fantastic, has always been hugely respected from so many people. So with all that in mind, without further ado, Pratik, if you don't mind taking us a bit of a journey through what the future looks like. We've had a fantastic overview as to what it has been. So let's hear from you as to what the future could look like without further ado.
Well, thank you. It's going to be hard to match that one. Let me just, can you just check that you are seeing my slides? Yeah.
Yep.
So looking ahead, and I thought, looking ahead and crystal ball gazing is always it's a fun pastime, but how accurately you can do it, it's as they say, I think, prediction is always difficult, particularly when it involves the future. but I thought I'd try and talk about things in maybe 4 domains and maybe prevention. So maybe moving towards a space where we don't need to use insulin, where this discovery of insulin becomes something of the past. Maybe that's an interesting thought to do. I think where a lot of the future lies, certainly the near future lies, is in devices. So I'll give a bit of an overview of that. And actually with devices, what comes together is data. And I think that's really where the big move will be in the next few years. And then finally, maybe a move towards cure, linking into the last slide from Professor Emil's talk. So if I take those 4 groups one by one, I think one of the interesting thing is that, is the incidence of type 1 diabetes is increasing all over the world. And so each of these different lines are the incidence of type 1 diabetes in different countries. And you can see whichever country you go for, since 1950, the incidence is almost doubled. Now, there's lots of thoughts about why and that might be, and that still needs looking into. But that, in effect, if you want to prevent diabetes, understanding what's driving this increase is really important. The other thing that I think is that I thought might be important, because I speak to a lot of people who are diagnosed, newly diagnosed, and worrying about whether it was that thing that they ate or that infection that they had that caused their diabetes. And actually, when you talk about preventing diabetes, you're looking at, there's a group of people who have a genetic predisposition. Now, not all of those will get type 1 diabetes, but something happens to them over time when they go into kind of what we call phase 2, which is there is an insulitis and inflammation of the beta cells and starting a low-grade destruction. And that happens years before people are actually diagnosed, often. And then you go down and that accelerates. And then finally, you've got clinical diagnosis when most of the insulin producing cells are destroyed. Maybe you've got about 5 or 10% of your insulin production left. And that's important to think about. Different treatment strategies or prevention strategies will find a place at different levels. If we start treatments when people have just been diagnosed, you've already lost a lot of insulin production cells over the years before you're diagnosed. And so there's not so much left to salvage. But if you start earlier, identifying these people without a widespread screening program is harder, because you actually need to stop people quite high up that level 2 or 3 years before they're diagnosed, if you want to prevent the disease. So that's something that I think a lot of the prevention community is dealing with. And you know, there are studies ongoing looking at those people genetically at high risk and seeing if you can do something widespread to those people. There is work happening in just finding, you know, siblings of people with diabetes who got positive antibodies or reduced insulin. And there are some treatments, some suggestions of trying oral insulin, trying some other immunological therapies, and then lower down, there's more aggressive intervention as you get down. And one of the first, you know, there's been billions of dollars thrown into early diagnosis and prevention of diabetes with not that great results, apart from this study that came a couple of years ago. And what you see here is, you know, in this red line, so people who were given the dummy treatment by 30 months or 36 months, by 3 years, about 40% of those people had got type 1 diabetes, whereas in the group that with treatment, that was only a third. So there was a significant reduction in the proportion of people progressing to diabetes with this drug called teplizumab.
Pratik, can I just interrupt you for a quick thing? Yep. I don't think your slides are moving. So do you want to give me control? No, I don't think that we are stuck at the, you know, the man looking at the crystal ball sort of thing.
Let me just hang on. Let me just do that one more time. Yeah. If not, I'll give you back here because you've got the slides. Yeah. Is that your screen share?
Yeah, that's definitely working now. It's working. Absolutely working.
Okay.
Perfect.
Those are the 4 steps.
Yeah.
Thanks, Martha, for that. And this is showing that actually with the treatment, you've got fewer people progressing to diabetes. So I think that's one aspect of the world. With the next 100 years, hopefully we can identify people earlier, give them treatment and slow down, even prevent their progression to full-blown type 1 diabetes. The major focus of what I wanted to speak about in my time was how diabetes technology has helped us use the insulin that's been produced. And in terms of what to do in any given situation, there are 3 stages to that, isn't it? The first thing is finding out what your blood glucose is. The second stage is understanding what the right decision is in that circumstance, taking all the different factors into account. And the third is then actually delivering the right amount of insulin in the most convenient way. And as we heard from Stephen and then from Prof. Emil, you know, measuring glucose has moved on from urine testing to finger testing to now to, for the vast majority of people living with type 1 diabetes, and a shout out, thanks, Partha, for all the work you've done in pushing those policies forward. We have the large proportion of people with type 1 diabetes now using some form of continuous glucose monitoring. from diaries and paper diaries, we now, many of you will have the experience of going into clinic and seeing the data and kind of having those data-driven consultations where, at least we're looking at information and giving something that's probably a little bit more valuable in that sense. And the way we give an insulin, we saw that insulin gun. I need to replace that picture with a picture of the insulin gun. We move on from pens now. Again, about a third of people with type 1 diabetes almost in the UK are on maybe an insulin pump. And the next step is, of course, a lot of excitement over the last year or so with a widespread rollout of closed loops, and I'll come to those in a second. So the reason why technology becomes really important, and I love this slide, which I got off a colleague called Gerard Riak, which is that task of checking your glucose, understanding and trying to work out what the dose it is, what dose to give, and then giving it. It doesn't mean, someone living with diabetes has to do that every day, in and out, multiple times a day for the rest of their life without any break. And he makes the comment that, everyone can do it, but the fact that you have to do it over and over again without stopping, without complaining or feeling bored, only a machine can do that properly. And I think that's why we look so much towards machines to help support people with type 1 diabetes and give them back some time that they were giving over to this condition. And glucose monitoring, we all know it's become less invasive and it's becoming less invasive. These are just some of the products that are going to hit the market in the next. Libre 3 has just been announced and will soon be hitting the market in the UK. Dexcom G7, there's a numerous sugar beat, and there are some further devices on the right-hand side which are still in development, which, a lot of the sensors we have at the moment still have a needle that goes inside the skin, even though many of us don't feel it. It's a problem for some people. So there are devices there that you can see with people trying to develop systems that are non-invasive, that don't even need a needle to pierce the skin, that can measure glucose outside. And there's lots of investment, lots of development happening in that field. In terms of pens, that insulin gun and the moving syringes have moved on to pens, and now the pens are getting connected. And again, it's about the data coming together. As I said, there are 4 connected pens that we'll see in the market coming through. And that means that, where did I give that dose or not? Can I remember? You can see what you gave when you gave it. And so, and that can be really helpful in working out what caused the problem, and knowing how much insulin has been delivered can be really important in judging what the dose should be given next and how you advise or make changes to your systems. And then, of course, the pump market is expanding and growing, and there's a large number of manufacturers in the marketplace: Medtronic, Tandem, Omnipod, Roche. There are some novel new pumps, particularly small, simple pumps that are trying to be developed for people with type 2 diabetes, saying that if we can develop them and avoid the needle the frequent injections, and those pumps, the suggestion is maybe they don't need all the fancy features of the other ones with type 1 diabetes, but they can be made simple and cheaper to produce. And so, again, more and more people would start, and these devices are getting smaller and more easy to use. But the big difference is automation. And again, those of you who follow things on social media will hear a lot about a big hybrid closed loop rollout in the UK. They'll be hearing about people with diabetes who've actually used their own ingenuity, use software programming to develop closed loop systems that take the data from your sensor, from your glucose reader, work out what dose needs to be given, and then deliver it, tell the pump to deliver those systems. There are, of course, commercially approved devices, and there are 4 devices currently in the UK. There's a Medtronic 780, a Tandem, a CAM APS, and Medtron. And all of those systems have the brains that control, that have a look at what the glucose is doing and work out how much insulin to give, all whilst the person living with diabetes can get on with their life. There are more devices, more systems coming to the market in the next couple of years. And these are real game changers in kind of helping deal with the variability, the day-to-day fluctuations that happen in life. And almost, the classical story, if you had a penny for every time someone asked me, I eat the same things and do the same thing, why does my sugar do something different, or why does it not behave as it should do? Well, these systems keep an eye on it and try to bring it down, try to control for it slightly better, keep an eye on it when you, irrespective of what you're doing. And just to maybe for those people who aren't that familiar with what the whole closed loop systems are about, what you have here, just to maybe try and explain that, is this is a blood sugar tracing, and this is going from midnight, and you can see over the night, then at 8 in the morning, patients had breakfast, sugar's gone up a bit and then come back down. They've had lunch, it's gone up and come down. So that's just the glucose wobbling its way around through the day. And underneath, you can see, normally if you have a pump or you have an insulin dose, the amount of insulin is very stable, a bit like this orange line there. But you can see here, in order to try and keep that blood sugar level in range, the pump is working incredibly hard. As soon as it sees the glucose rise up, it gives a little shot of insulin. As it starts coming down, it winds it back down again. Still though, with these systems at the moment, the pump can't predict when you're going to eat something and how much you're going to eat. And so you can see these blue bars are when the patient has told the pump, look, I'm eating 2.9 units worth of food. And so they've given the dose, but actually they must have not quite given enough, because you can see that the pump has then chased it down as the sugar's risen with a little bit more insulin after the meal. And then as the sugars come down, this blue line has dropped off, so it stopped it. So it's a bit like someone adjusting the throttle pedal on and off, depending on the rise and fall of the road, trying to keep your speed constant, trying to keep your glucose constant. And again, you can see it doesn't create a flat line. There's still some rises and falls, but actually it's reduced the amount of work that person has to do to get that level of glucose control. And, you know, when we look at the data, these are data from one of the commercial devices, and they're showing that using their closed loop system, almost 80% of people got to a target HbA1c, target glucose control. And that number is sitting around about 30% currently for people living with diabetes. And again, Partha and a number of us involved in, I think we've got over 800 patients enrolled in this hybrid closed loop trial for managing blood glucose in the UK, and hopefully the data from that will inform nice guidance, helping that technology to be available to a wider group of people living with diabetes. I want to mention that, you know, although I'm looking back a bit, I think, you know, we started off talking about how 1 injection a day and urine testing, and then we talked about many people have been on 2 injections a day. Some people diagnosed in the 80s, standard of care was 4 injections a day. In the 2000s, standard of care was maybe give someone an insulin pump. And maybe in the last 5 years, it's, you know, here's a CGM and here's a pump. And we've been asking people to do more and more work. You've been getting better results, but you know, look at your sugar level, take a tiny dose of insulin, take a little bit of carbs, but be much more involved with the diabetes thing. And I think these closed loops mark a really important game change, where actually now with the technology, the amount of work, we're on the downslope of that hill, that we're going to ask people to do less work, let the machine do a lot of the heavy lifting, you give it a bit of guidance, and we're going to get even better results with less work. So there's a separation between the amount of work we're asking people to put in and what results people will get, hopefully. However much we think about technology, you know, at the moment, this is probably the wrong way around. Yeah, sorry. At the moment, we've got a small amount of people on closed loop and a large amount of people on injections, and maybe some people who just use the CGM or pumps. And that will change, hopefully, in the next few years. You know, the amount of closed loops and technology will increase, but we'll still have a lot of people who are using insulin injections and traditional therapy within the UK, but also certainly in other nations. And that means, you know, getting better insulins is going to be quite important. And just to look at some of the things that are being tested on the horizon, how many of these actually reach commercial use and get available to us is variable. But, you know, for people who need very stable doses of insulin, maybe people with type 2 diabetes, having insulin patches that use tiny needles to give insulin at a very stable, constant level over time are being developed. The smart insulins, which as soon as they get in contact with sugar, they change shape and so become active. And when there's no sugar, they change shape and become inactive. And so that's really exciting development. And the idea is that, of course, it might reduce the amount of hypoglycemia people have. Again, that sort of technology is probably more relevant to your people on once daily long-acting insulin, which just kind of slightly adjusts its dose. I don't think it translates into insulin that one shot of insulin that will cover everything. This is the inhaled insulin that Prof was talking about. Frets are the sort of inhaler. You take a tiny squirt. It's available in the US. And then there's oral insulin that's being developed. Again, from what we can see, the oral insulin won't have the adjustability that we get with pumps and technology, but it might be a good alternative for people who need kind of stable, fixed doses of insulin. And then I came across a company that's developing the watch that has an insulin solution in it, and it will get through the back of the pump. It has tiny microneedles that it develops in, so a more discreet way of delivering your insulin. But where the biggest development in the future is going to be in data and technology. We're all kind of a smartphone revolution. And data is really king. And many of you will have diabetes devices that show the data. And these are now critical to the way healthcare professionals interact with patients. And actually, we're going to add to that, I think, in the next 10 years, we're certainly going to see the role of wearables. And that is things that monitor your sleep, your food, your activity, your mood, maybe, coming in and us being able to use those data to better fine tune the insulin delivery and the way the systems work. And we already have a lot of apps that collect data, but the important change that's going to happen in the next 10 years is that this data will change from a data collection device into an advice device, taking away the mental need to do all those calculations of doses and be able to adjust the dose you need based on what you've been doing, taking data in from what's happened before and using artificial intelligence in a way to manage that. So what I think is, the way we're using technology at the moment is maybe a bit like when I bought my first iPhone in 2005. I just used it like a normal phone and I wasn't aware of all the things it could do. And at the moment, we're just using pumps as a way to deliver insulin and sensors as a way to measure glucose, but we're not really using that information. We're starting to use the technology a little bit better to maybe interact in a more convenient way with our patients. So, many of you over the last 2 years will have had virtual appointments and will have been, seen the convenience of being able to do those at work or not having to take the day out to go to hospital, but also the advantage of having data in those consultations. But we still have to try and tease out where that data sits. And a lot of the data sits with the patient, some of it sits in the devices. There's a lot of data sitting in hospitals. And at the moment, these data don't really talk to each other. And that's where a lot of the progress is going to happen over the next few years. And maybe we get to this stage where we're on the cusp of this now, where we have closed loop systems, which kind of take the sugar data and tell the pump what to do. We get some systems, some apps coming through that are giving intelligent dose advice, but we've still got a way to go. The technology will get really smart when the data will go from your wearables and devices to the cloud. They'll use big data and machine learning and artificial intelligence to work out what you need to do and provide you with information then and there, the doctor in the hand, so that you take away the workload of trying to work out what do I need to do to adjust for what's happening. And that makes the support that our team provide more intelligent as well. And maybe with data coming through, what we think people want is they want help when they need it, not every 3 months or every 6 months according to a fixed appointment. And so as data comes through, we can target the limited healthcare resources more to the people who need it the most and have a watching brief on others, letting the data, the apps, the artificial intelligence drive support people for all the time they're out there. And that to me is where unleashing the full value of the technology and the wearables that we have at the moment. And finally, just a couple of words on cure. So in the UK was the first country in the world, and actually led by Professor Emil, we set up the first islet transplant program in the UK, supported by Diabetes UK. And this is just a trace of someone who had really difficult to manage diabetes, multiple ambulance call-outs from hypos, and a few days after transplant, they've got this flat curve on their trace. The cost of that, though, is long-term immunosuppression. And the fact is that in the UK, we do maybe 20 to 30 islet transplants a year. The major challenge for those is supply of organs, and then getting the islets out of the organs, and then getting them to survive long enough. Those islets have a lifetime of 5 to 7 years at most with current therapy. And there's lots of different ways trying to improve that, but trying to translate some of that science into clinical practice is very challenging at the moment. We have a lot of news stories looking at further developments and advancements. And this basically is the recipe. If you have all of these chemicals and all of these pluripotent stem cell, you mix it with these chemicals for 14 days. At the end of it, you will get a cell that will make insulin. And that recipe was published about 7 years ago now by a group from Harvard. Now, the problem is getting those cells, making enough of them, getting to survive, and finding a way to deliver them safely to people with diabetes, such that if they go rogue, you can get them out. And so that's where a lot of the world around the stem cell therapy is looking at these sort of devices that you can package millions of cells into, put under the skin of someone living with diabetes, and then these cells can provide the insulin long term. And if they die out, you can take the device out, replace the cells, and put them back in. And that might be one of the ways the world is going. So I think if I'm looking at the short term, I don't know about the next 100 years, but certainly the next 10 years, certainly I see the shift has gone from in the 1900s or 1920s from preventing death from diabetes to the last 30, 40 years of preventing complications of diabetes. And I think the next shift is going to be about reducing the burden of living with diabetes. I think connected technologies are helping connect people with diabetes with healthcare professionals, maybe creating communities of people who are supporting themselves, as we've seen on social media. I think the next early step that we're going to see is assisted decision making, just helping take some of that mental tension out of what to do when, and whether it learns from what it's doing and it can make a unemotional, clear judgment of what you want to do. And then I hope there's finally some slight light at the end of the tunnel about preventing, delaying diabetes and offering a cure in terms of cellular therapy. And that's in the kind of longer term 20 to 30 year horizon. I think we'll see some benefits in there. So thank you very much.
Thank you as ever, Pratik. That was fantastic. Again, 2 back-to-back fantastic talks preceded by views from people living with. I was just wondering if all the speakers could come back on screen, because I was just going to ask a few questions, and if our DSN forum colleagues also join us back in, Becky, if they want to have some questions, because just wanted to have from my end a couple of questions for everybody who's around. And to begin with, if I may start with you, Pratik, because you've finished here, so don't worry, I won't be making any jokes. Very serious, right? But hey, to everybody who's listening, now you've known that you've heard him speak, and this is now forever there to be listened on record. He's not just a handsome face; he's a very clever man too. So there you go. There's proof there forever. Pratik, one question is: you've been involved heavily in research and academia, and also now into policy and all that sort of stuff. Looking back over the last, we started a journey as registrars together, and we're here. Looking back and forgetting politics, in the science sector, what would be your one thing you would have wanted to change? You would have said, if we had focused this, as regards insulin or type 1 diabetes type 2, we could have done better. I mean, this is a pure academic question. Forget the politics. Politics is what it is. Academia-wise, where do you think we might have missed out doing something early in the research side of things, just from your point of view? And you're allowed to be as controversial as you want. You're on mute. I think you're on mute.
I think we can use the data that people are generating better. At the moment, we ask a lot of people living with diabetes, and there's a part of me, I'm completely sold on you. The person with diabetes needs to, it's a bit more the Steve Jobs mindset that, rather than giving people endless choice, you give something a box machine that just really works. And we've given, sometimes too much choice can be a challenge, and all these algorithms and rules and things that you need to learn because we didn't have the black box. And as that comes, the faster we can get that out, I think that helps. And maybe part of me thinks, as of today, the biggest change will happen the more people that get onto an automated closed loop. To my mind, if you could get a closed loop to every person living with type 1 diabetes, then life-changing complicated blindness and amputation will be a thing of the past. Wouldn't happen at all.
All right. So, quicker, faster towards it. Angie, if I may take a bit of a switch change and come to you, because we've talked a lot about type 1 diabetes, obviously linked in with insulin stuff, and you've made the very good point, about, living with type 2 gestational, there's a massive, massive group of people. And I think, this morning I saw there's 1.2 million people in this country on insulin, of which 0.2 is actually type 1. The rest is all type 2. From your point of view, what would you say, in your experience, that we could do better with insulin for people with type 2 diabetes? What's your personal view that we don't do well enough or could be done better?
Me personally, when I've said what I think to other people living with diabetes in a similar position to me, a lot of them have disagreed with me. So it's difficult. But from my personal point of view, when I was initially diagnosed with type 2, I was given a load of tablets and told, within 6 months, we'll have this under control. And it wasn't. Then I was told, you'll take insulin and you'll take less tablets. But I wasn't. And although I really appreciate and wouldn't ever say, no, I don't want to take insulin anymore, because I'm so on board with the difference it's made to me, I do kind of also feel that, but you could have told me that and been truthful in the first place, because there's ways, obviously, of delivering bad news and saying, you know, obviously you want to be able to say to somebody, yeah, we're going to sort you out completely in X amount of time, but the reality is it may not happen, because particularly with type 2, there's so many other things that can affect it all. You can't give a definite answer. So I think personally, to say up front, well, this is what we'd like to aim for, but other things may happen, so but we're going to work together. And then I think you feel more on board with accepting the changes and feeding back.
Okay, thank you. Thank you. Stephen, I'm going to go to you. And this is a very different question. You talked about your experience living with insulin. You've had it for such a long time. If by magic, tomorrow morning, we gave you something, you never needed insulin anymore, right? Tomorrow morning, there's no more insulin needed. Given that you live with it and it's part of your life, the reason I'm asking that question, some people, and it sort of follows a little bit from where Angie said as well. A lot of people say, it's become a part of my life, right? I cannot believe. Would that be like a loss, or would that be like a relief, given that you have had so many years of living with it? How would you see it from your point of view?
That's a perfect question, because there's something I was wanting to introduce that hasn't been mentioned at all. Would I take it? Yes. However, type 1 diabetes has had a psychological effect on me, I believe. My question is it my genetics that makes me what I am, or is it nurture? So throughout my life, it's been up to me. And if you don't do that, you'll only take ill. So I've had this, I see now, a huge pressure put on me. Sometimes I was naughty, and you forget that you mustn't be naughty, but a psychological pressure has been put on me. And my character today is one of, with everything in life, it must be my fault. Why? Because as a type 1 diabetic, as a juvenile type 1 diabetic, I was told it's up to you. So if I could have a magic cure, yes, I would take it, but I'd still be living with the psychological burden. And what I'd like to point out on this final comment, being brief, is not once, and it's not criticism, I just thought it was wonderful, not once has psychology in type 1 juvenile onset diabetes been mentioned. Not once has the psychology of having diabetes been mentioned. And I'm glad you've given me the opportunity indirectly, Partha, to actually bring that up.
I would say, and I'm actually going to go to Prof. Emil with the question in a second. I think you absolutely hit the nail on the head. If, you know, my personal view is that forget diabetes for a second. If you park it, I think we make a mistake of making physical health and mental health so separate. And I think that's one of the failings of the NHS, that we made it into two separate entities. And we are in a situation right now that we have to justify the role of a psychologist in our department when they should be part and parcel of somebody's diabetes journey, just like a dietitian is, just like a nurse is. But we're not in that position because suddenly it's an add-on. And I think that's a fundamental problem as to how we do healthcare, not just diabetes. I think there's a lot beyond diabetes. People who live with long-term conditions, you know, for their lives, mental health is a big issue of that. And I think that's something which you hit the nail on the head, and the NHS is trying to work towards it, but it's a long haul towards it. As we are talking here of our nurse colleagues, ourselves, who are really there trying to, and we struggle ourselves trying to get psychology into our services, as you would imagine. So that's
and also part of the problem, and sorry, I'm interrupting you.
No.
Part of the problem
it's just like clinic
is medication for, if you like, mental approaches is such a huge challenge, and it's going to be for more years than the control and perfection of the control of diabetes. So I do understand that. I think, though, if the NHS would all just give more money to talking and the talking support in the mind, that would be a fantastic start. Thank you.
Wonderfully said, Stephen. Prof, you had your hand up. I've got a question for you, but please do contribute and then I'll ask my question.
Well, no, if I may, I wanted to respond to Stephen. I'm rather thinking I should preface this by saying with age comes wisdom, Stephen, and I'm talking about me rather than you. Because actually, in fairness, I galloped through my history because of the time limitations, but you might have noticed there was a sneak mention of something called HarpDoc at the very end of what we do in terms of talking to people. And where I have come to understand what you're saying over the years of working with people with diabetes is that we are very much now looking at psychological impact of, and it actually goes back to something Angie says, because I work a lot with people who struggle to avoid hypoglycemia. And what we have found is that if you are in that unfortunate group, then there are a lot of issues, but many of our patients say to us that it's something that was said to them by a healthcare professional at the start of their diabetes, that has made them so worried about ever being high that they don't worry too much about being low. And I think there is a growing recognition of the importance of how we talk to people, how we should, as Angie put it, breaks bad news and tell people what the future is, how we need to be honest with them. Taking, for example, people with type 2 at the very beginning and saying, well, ultimately insulin becomes necessary at the moment because that's how the disease evolves and we don't have the treatments yet to stop that. So I think your point is very, very well made. And I think that might have been my answer to Partha's question to Pratik about what's the one thing that we've missed out on. It's actually the way we communicate with people, and the way we use all these wonderful tools that are becoming available to us. So I'm with you on that altogether. Sorry, Partha, you had something.
No, not at all. Not at all. Thank you. So just before we go to the quiz, I think that we got a couple of questions, and I'm going to actually put one of them to you, Prof. Don't worry. My initial question was, who is your most favorite person who has done research for you? But because Pratik's here, we're not going to make him feel embarrassed. We're not going to go to that question. We are going to do something.
Love them all.
That is the perfect diplomatic answer. That's not what you told me, Pratik, when we met, but that's okay. But question for you is, and it's a good question which has come up. Do you think we will ever have a cure, or do you think tech will develop to the point that will be as much a cure as feasible? What would your view would be?
I would like to think that we will have a cure, but as I've been saying to people for a long, long time in clinic, and I have been for many years running clinics, we're always talking about something that may happen in 10 years, and a lot of 10 years have gone by without that cure manifesting itself. I think the technology, I'm absolutely with Pratik in that what we need to do is get the technology so good that the person doesn't have to think about it. And I think there will come a time when the technology is close to that. I don't think it will ever be that good. Will transplantation provide a cure? There are so many things that you need to do to sustain a transplant that it's sort of changing one set of self-management rules for another. I'm more inclined to think that there might be a way of preventing more diabetes happening, but I'd like to think there will be a cure. I think that's the way we're moving. That's the holy grail that we're chasing. And as we chase it, we are going to make the discoveries that make things easier for people. So if we haven't got the perfect technology to be an artificial pancreas that I just put into your body and it does what the pancreas does, but we have got hybrid closed loops as we move towards it. We haven't got islet transplants perfect they don't cure diabetes at the moment, but at least we've got a cure for hypoglycemia while we work on it. So I think we have to believe that there's a cure because we have to go on striving to find one. And that way we will just make things better along the way, and hopefully we'll get there, but I couldn't possibly put a timeline on it.
Thank you. Thank you.
If
Now,
I could be,
yes,
if I could
go
be
on.
so bold,
Please.
yeah, I think it's wonderful what's been said. I would actually change the comment, and that is, actually, we have a cure. Today we have genetically produced human insulin. That's the cure. It's now the perfection. So I'm picking on your words, Partha, but in the nicest way. Yes, we're there, and now we're fine-tuning it. And to me, it doesn't have to be the Langerman cells. We have human insulin. Let's now perfect it. You know, so I would like to think I'm very upbeat that way.
So, Amanda, we got one question. Do you want Pratik to answer that in 1 minute? Will that delay the magnificent
No,
quiz?
that's fine. I can speed up the quiz.
Okay. So, Pratik, question.
But everybody, can you everybody get a pen and paper ready or notes on your phone ready to do your answers? Not you guys.
No.
But
Yeah,
the
pen and
people
paper
at
wasn't for
home.
my-
The
it
people
wasn't-
at home.
It wasn't for my answer.
So,
Right.
Pratik, question, and I think it relates to a lot of the work that we are doing at the moment, closed loops, right? Who owns the data and how can you minimize the risk of hacking? That's an issue, that's a question. Lots and lots of debate around it, where we sit with that, and a bit of a logistical nightmare, but what's your view on that?
So for any closed loop at the moment, commercially, when you sign up to a closed loop, the glucose data, the insulin data, almost all the companies, you create an account that the person living with diabetes has access to. And at any point, they can pull the data down that says, what's my glucose, what's my insulin? So in that sense, they have access to that data. Actually, you have to tick a box to say, do you want to have the company to have access to that data, which they can use? And actually, we find value in that use because, for example, at the last conference, one of the companies was able to show, both major closed loop companies have shown, well, here's 10,000 people using the data. And you learn from how they're being used, and we use that information. So the data is available to the person living with diabetes and to the company, and it's used in that way. And I think people have the right to block access to that to the company to use it for most of the systems that's out there. As regards the hacking question, you know, there are quite a reasonable amount of security protocols around the way the insulin uses. That's why you can't doze off mobile phones for many of the systems. But you know, people can hack into it. The risk is minimized with the software. And actually, there's been, you know, these systems have been out for a long time now, and the reports of hacking have been, there haven't been any reports I'm aware of hacking in outside of people who have really focused on trying to do it and demonstrate what could be done in academic settings. So the real risk is low. That's my
Okay. Thank you. So I'm just going to wrap this up by saying, amazing. It's been so much fun. And I'm just thinking, you know, we need to, when times are better, we need to do this in front of an audience with lots of more people, because it's such a rich way of interacting with people. Absolutely loved it. So we'll wrap here. Thank you, Prof. Thank you, Pratik. Thank you, Angie and Steve, and obviously others so far. But the fun part starts now for those of you who have tuned in. I'm going to leave it to, is it Amanda and is it Tamsin doing it this one? Excellent. So over to our fantastic DSN Nurse Forum colleagues to do the quiz, and we will listen in.
Thank you very much. So everybody, hopefully you've managed to get a pen and paper. If not, notes on your phone, because you need to know what you've put for your answers so that you can know whether you've got the right ones or not.
And I hope you've been listening into all the talks, because we've noticed there's some answers in there. So
we might have had to change a few spellings and maybe whilst we've been watching the talks, but hopefully it'll work fine. Right, so I'm just going to share my screen. Hopefully you'll all be able to see it. Are we good?
We're good to go.
Brilliant. So this is the Diabetes 101 Insulin Quiz. Test your knowledge. Okay, so I'm using Canva. If you score between 0 and 10, you will be part of Team Bantin's Besties. If you get 10 to 15, you will be part of the McLeod's Marbles. But if you get 15 or more, you will become part of Team You Can't Diabetes. Woohoo! So keep a track. Right, are we ready for question 1? True or false? Insulin is a hormone. They're not very difficult, I promise you. Is it true or is it false? Question 2. What is the name for a blood glucose of less than 4 millimoles? So we've got Rolo, YOLO, Hypo, or Go Slow. I think some people might think it is Go Slow. Right, question 3. True or false? Most insulins are safe to keep at room temperature for at least 28 days. Is that true or is that false? We are now on question 4. I feel like I need some music playing alongside, like we did with the Who Wants to Be a Millionaire one. Yeah, this is very quiet. Right. What is the recommended needle size that you need to inject insulin? Is it 4 millimeters, 12 millimeters, 8 millimeters, or 10 millimeters? Question 5. True or false? You may need more insulin when you are unwell. Told you they were easy. Ooh, no, I didn't mean to do that. Okay, next question. Think about what year this is. What year was insulin first used to treat a patient? Was it 1912? Was it 1922? Was it 1932? Or was it 1942? Question 7. True or false? Durocells produce insulin. Question 8. Hopefully I'm not going too fast through these. We're going to have loads of time. Loads more time for questions. It's fine. What was the name of the first boy treated with insulin? Was it Jaden, Brooklyn, Leonard, or River? They do get a little bit harder towards the end, honest.
They get very hard at the end.
Very hard. The last few are very hard.
Very hard.
Question 9. True or false? Insulin is injected into the subcutaneous layer of the skin. Question 10. Which cells produce glucagon? Is it alpha cells, beta cells, sperm cells, or prison cells?
You can tell we were amusing ourselves when we were doing this.
These are actually ones that we used with healthcare professionals on DPC. So some of them. Question 11. True or false? You need to keep the needle in the skin for 30 seconds after you inject. Question 12. How do you dispose of used needles? In the household waste? Leave it on the pen forever? In the sharps bin? Or in your handbag? Question 13. True or false? You should store unopened insulin in the fridge. Is that true or false? Question 14. How often should you check your blood glucose if you're driving and you take insulin on long journeys, say? Would you do it every 30 minutes? Would you do it every 2 hours? Would you never do it? Or would you do it 6 hourly? Question 15. True or false? You should store your insulin in the hold of an aircraft when on a flight. Is that true or false? Question 16. What was the first wearable insulin pump called? Was it a red brick, a blue brick, a yellow brick, or a green brick? What was the first wearable insulin pump called? Red, blue, yellow, or green? Question 17. Ooh, what happened there? I went backwards one. Charles Best's aunt had diabetes. Is that true or false? Question 18. What was the first insulin extract also known as? Was it Collip serum, Banting serum, McLeod serum, or Best serum? What was the first insulin extract also known as? Collip serum, Banting serum, McLeod serum, or Best serum? Question 19. True or false? The first wearable insulin pump was designed in 1978. Is that true or false? There might be a bit of argument with this one.
According to Wikipedia and Google sources.
Professor Emil, we had to change the date that we had. So this one we might have to give you half a point for this one because I think we had it wrong to start with. Okay, question 20. Who fully sequenced the amino acid structure of insulin? Was it Albert Singer? Was it Francis Crick, James Watson, or Frederick Sanger? We had to put in a hard one because we couldn't give you all the easy ones. We had to put in a difficult one.
I wanted to put in the chemical structure of insulin, but everybody shot me down. So
we did do that for the healthcare professionals at DPC. None of them could do it. They didn't know the answer. Nobody knew the answer to that. We gave it to the best guess, which was actually quite a good guess. They got a lot of the bits that are part of the structure. Right. So are we good to go to the answers? Right. So I will hand over to Tamsin now.
Okay.
So answer to question 1. This is a reminder of what the question was.
Okay, so is insulin a hormone? I hope we all got this one right because it's true. Okay, what is the name for a blood glucose less than 4 millimoles? I hope you all went for number 3 and hypo.
Oh, I went backwards. Sorry, I'm not used to Canva. So it should be that one.
Yay, hypo. Most insulins are safe to be kept at room temperature for 28 days. And that one's true. So it's just an odd few that you can keep for a bit longer outside, but 28 days is pretty standard. What is the recommended needle size to inject insulin? And that's 4. So some of the older people on the panel will probably remember that it was much bigger needles than that when they first came out, but 4 is now the recommendation. You may need more insulin when you are unwell. True or false? Yeah, and that's true. Just generally, just because you're feeling a bit grotty and stress and everything else like that, tends to find that you need a bit more insulin. So what year was insulin first used to treat a patient? And I hope we can all get this one right, otherwise we all need to be banned off the 100 years of insulin tonight. So it's 1922. And then Duracells produce insulin, true or false? If only Duracell did insulin, because it would be much easier to go get it probably, but that's false. Yeah,
It's beta cells for anybody that didn't know.
Okay, what was the name of the first boy treated with insulin? So treated obviously today, and his name was Leonard. So insulin is injected into the subcutaneous layer of the skin, true or false? And that one's true. And this is the flip side of which cells produce insulin. So which cells produce glucagon? And that's the alpha cells. And you need to keep the needle in the skin for 30 seconds after you inject. I hope this one's not true, because that's definitely a bit too long. So yes, 10 seconds is usually the recommendation. How do you dispose of your used needles? And we don't, in the shops bin, we don't want to know about any other places that you might keep them. But yeah, in the shops
I bet there's some stories.
And you should store unopened insulin in the fridge, true or false? That's true, yeah. Keep it out for 28 days if it's out. How often should you check your blood glucose if you're driving and you take insulin? And that's every 2 hours as per the DVLA guidance. And you should store your insulin in the hold of the aircraft when you fly. Is that true or false? Yes, 100% false, because otherwise it freezes. So definitely keep it in your hand luggage and with you.
Otherwise, it also could end up in a different country.
Indeed, yeah, which is not a good idea. And what was the first wearable insulin pump called? It was the Blue Brick. And if you go and have a Google of that, you can see lots of pictures of it. It was huge and was like, yeah, nowhere near the size of what we have now. So Charles' best aunt had diabetes, true or false? And that was true. We're getting some more tricky ones now. What was the first insulin extract also known as? And the McLeod serum.
I never know how to say it. Is it McLeod? Is it McLeod?
I said McLeod, I don't know.
Who knows? Who knows?
It just rolled off my tongue. The first wearable insulin pump was designed in 1978, true or false? And this is a bit of a 1976, 1978. There's like a different.
We've gone with Professor Emil because we think, you know, she knows her stuff. So we're going to say true, but we'll also accept 1976 if you have that from Wikipedia.
And also
we'll also accept false.
Yeah, wasn't it from the Diabetes Encyclopedia as well?
I'm not entirely sure. Yeah. Google was not our friend today.
Yeah. And who fully sequenced the amino acid structure of insulin? And if you were listening to obviously the talks not too long ago, it was mentioned in there. So it gave you the answer, and it was Frederick Sanger. So that was the last one, wasn't it? Yeah. So you just need to total up 1 point per question and let us know how you did.
Who's in what team? Are you in the Bantings best team?
So,
or are you in the McLeod's Marvels? Or can we not diabetes?
Yeah. So, but post your team in in the chat and in the YouTube
Or
chat.
tweet us.
On Twitter. And we can celebrate with you if you got whatever you got.
I think we're probably a bit early. Oh, how do I get?
I think the general consensus for the pronunciation is McLeod coming from YouTube. Just
how do I stop sharing?
There you go. I did it for you.
Thank you. I don't use Zoom. It's difficult. I use Teams.
Okay, that was a great quiz, guys. Thank you. Everybody on YouTube, if you post in the comments your scores, we will get Partha to tweet all about you. So that was amazing. I've learned so much. Stephen and Angie, your positivity on using insulin was amazing. Both your journeys with type 1 diabetes and Angie with gestational, and then moving on to insulin has been brilliant. Prof. Emil, I've learned so much about where we've come from with insulin so far. The last 100 years, it's been amazing. And I didn't know that the first injection didn't work and actually caused large abscesses at the site of the injection. And the second injection was given on the 23rd of January when it was more purer extract was given. So
are we all coming back on the 23rd of January and doing it all again?
Was it the same child?
Yes, it was still into Leonard. Yeah, but he had to wait until the 23rd of January for his second injection. So
wow.
I can imagine how horrific that must have been.
Yes. Yeah.
I would just like to say thank you to pregnant mums with diabetes, because my understanding, when I got the laser light treatment, they reckoned it was treatable because the observation of the aneurysms was actually made, I was told back then, in pregnant mothers. And during the expectancy, their blood sugars got out of control, the aneurysms occurred, but after the pregnancy, the aneurysms disappeared or at least did not develop. So I would like to say thank you to the doctors that spotted that, and thanks to the pregnant mums, because it then helped to progress the laser light treatment of that, knowing that it was potentially, and with good control, curable. Thank you.
That was.
They're now leading the way with CGMs now, aren't they, the pregnant ladies?
Yes. Yeah, pregnant mums do an amazing job with much tighter management than anybody else, and I think they're amazing to get themselves and the babies through safely. They do a brilliant job. Patrick, your mountain allergy was brilliant. I know that you've said you've pinched it off somebody else.
We're all stealing it from you now. So
but yes, we're all stealing it from you.
Adapted.
Inspired.
Yes, definitely. I think showing that we've increased the burden by asking people to do more and more and more, but hopefully, fingers crossed, with closed loops, we are now on the downward slope.
Downward roll.
Yes, yeah. Tamsin, was there anything you picked out of the talks that you wanted to mention?
I just think, pretty much everything that you said, from the people that, live with diabetes, you always learn so much, I think. I would agree. I hold my hand up. I've had diabetes for 40 odd years or so, but only in the last 9 years have I been working in the diabetes field, and it's always been that your diabetes really better than anybody else. And working in the field now, I hope that I give that back to people in the sense that I show some empathy, and things like that, and I think that's important as well. Treatment is all well and good, really, but actually, if you don't have a good support system when it comes to diabetes. It is a very tough condition to live with. So I think listening to other people have diabetes it inspires you, I think, to do better and work better in different ways, maybe, and listening, you know, with hope really to the future, because you know, I do, you know, my parents had the 10-year cure talk, you know, when I was diagnosed, and I know that, and you know, 40 years down the line we're still not quite there, in the sense of that, you know, you can forget that you've got diabetes, but hopefully that is coming, where you don't have to always think about it, and it's not always in the back of your mind, and it's not waking you up at night and all those sort of things. And I think probably, you know, the final thing I would say is, you know, today's 100 years of insulin, and you can't really go any further without thanking all those people before us who have done all that hard work and actually found that, you know, that drug that actually, you know, keeps people with diabetes alive, because before that it was an absolutely horrendous struggle to survive, even for a few years, really. So, you know, thank you to all of them, and thank you to all the other people that are continuing to do research when it comes to diabetes in the future.
Brilliant. And yeah, I really liked Prof. Emil's thing on, you know, on our way to hopefully getting a cure, we can hopefully make things easier to live with along the way. I think we've got about 10 minutes left, so I'm going to throw it over to Partha to see if he's got anything inspiring to end us off with.
You're not 10 minutes worth, so we'll try and give a few minutes back to all of you in your evenings. But I think last few things to say. I mean, we've made our thank yous to everybody, and Becky, I think it would be unfair for us not to mention you for all the help with all the tech and everything that sort of ran. So thank you so much for that and coordinating all of this. And as I've said, everybody giving up their evening for this. I think to everybody who's listening, I think generally speaking, people are divided into people who are either carers in the form of clinicians, or parents, carers in general, or people who live with diabetes, any type. And I think I always like to say to people who, whatever type your diabetes is, we are in a phase whereby we're coming out of a pandemic, fingers crossed. It feels like deja vu. We've said that before. So hopefully we are there, we're getting there. And we've got a lot of work to do in trying to catch up with care. But I think don't forget that over the last 10 years or so, diabetes care in this country has actually gone in the right direction, whether it's, you know, foot care, whether it's generally speaking, you can see the improvement that's come through, new drugs, new technology. And I don't think there's a lack of people who are trying what they can do to try and improve care. So I think that's the message of hope that I would like to leave with every one of you. And I think to clinicians, probably, I think just to mention, which Tamsin just said, I have learned that, and that's not been my style, but you learn that along the way, which is don't judge somebody whose lives you don't live. It's as straightforward as that. And I think if you take that approach, where you, in your clinical setting or wherever, you have that view that, look, you know, as my opening gambit over the time in clinic has changed to, I don't have type 1 diabetes, I never inject, I've never had a hypo. And that's the reality of where you start off with. And I think the rest of it falls in place for me. So I think that's the message probably to leave everybody with. So there is always hope. 100 years today, with 2022, we're starting off on a new journey. So hopefully with all your support and from all of us here, again, a big thank you to all the speakers. Thank you to everybody who's listened in or who will listen in later on dial in. So we'll wrap it up here. We'll give you 10 minutes of your evening back, and we wish you all a fantastic evening going forwards. Thank you so much.
Thank you.
Bye.